morning, madam.
Good morning, madam.
Hi, morning, Srinivas. Chandana.
Morning, madam.
Chese. Share sounded. Priya, share.
Madam, కనబడుతుంది ఇప్పుడు స్క్రీన్ మీద. Good morning, Mohan sir.
Good morning, Mohan sir.
Good morning, sir. Start చేయండి sir. అందరూ స్టార్ట్ చేయొచ్చు కదమ్మా. శ్రీకాంత్ లేడా?
ఉన్నారు సార్ శ్రీకాంత్ సార్.
Sir, good morning.
స్టార్ట్ చేయండి శ్రీకాంత్.
Sir, PPT sharing కొంచెం ప్రాబ్లమ్.
ఇప్పుడు నా ఫోన్ నుంచి షేర్ చేశానా లేకపోతే ఈ రోజుకి?
నేను షేర్ చేయను మేడం, లేకపోతే
షేర్ చేసే చైతన్య లేకపోతే నీ దాని నుంచి. అనురాధ మేడం, చైతన్య దాని నుంచి షేర్ చేసేయమని చెప్తున్నా.
చేసేయండి తొందరగా చేసేయండి.
మేడం ఇందా నుంచి పాపం కష్టపడుతున్నారు సార్ దాని గురించి.
ఇప్పుడు కష్టపడి కొంచెం ఆపొచ్చు కదా, ఇంకేముంది.
షేర్ చైతన్య ప్లీజ్ షేర్ అమ్మా. సో నాకేం కనబడట్లే. నేను నా దాని నుంచి షేర్ చేసేస్తున్నాను నా స్క్రీన్ నుంచి.
కనపడలేదమ్మా, నీకే కాదు.
నా ఫోన్ స్క్రీన్ నుంచి షేర్ చేసేస్తాను. Yeah, okay. Thank you, Chaitanya. Anuradha madam, thank you so much. I am sorry for troubling all. So I'll start the topic. So the topic which I'm going to talk about now is obstetric hemorrhage and anesthetic perspective. Next slide, please. So as we all know, it's a filled with blood and it's a bloody affair. And why is it important? It is because of its emergent nature, and it's a leading
affair.
Sir?
Nothing. Sorry.
Yes, sir. The points of interest are here. It presents in an emergent way many of the times, and it's a leading cause of mortality and morbidity. About 10.5 to 20% of maternal mortality and morbidity are accounted for hemorrhage. There is a difficulty in estimation of blood loss. We'll talk about it later. and there is a need for continuous adaptation and decision making according to the patient's condition, and needs team effort more than any place, and multidisciplinary. Next slide, please. So grossly, we have it's divided into antepartum hemorrhage and postpartum hemorrhage. Coming to antepartum hemorrhage is defined as any hemorrhage which is occurring after 24 weeks of gestation and before delivery. And in some institutes, even 20 weeks is taken as a cutoff point. So many causes are there for antepartum hemorrhage, but major important causes will be placenta previa, abruptio placenta, uterine rupture, vasa previa. So here we can see two pictures showing one is placenta previa and the other is abruptio placenta. Placenta previa is nothing but abnormal implantation of the placenta. It can be a low implantation or a partial placenta previa or a complete placenta previa, depending upon the extent of placenta covering the cervical os. Marginal when there is a distance of about 2 centimeters from the os. Partial is it's incompletely covering the os, and complete placenta is completely covering the os. And coming to abruptio placenta, it is the abnormal separation of the placental lining from the uterine wall, and there will be a collection of hematoma, and it can be a revealed hemorrhage or a concealed hemorrhage. Next slide, please. So before we go into the depths of it, so we'll just discuss few most likely ways of presentation of these patients. For example, we can see that in all the 3 examples which I am quoting, everywhere we find that there is a vaginal bleeding. So, but how do we go about during our diagnosis or clinical diagnosis part, and how do we differentiate, and how do we come across the likely management scenarios? So first example is a third gravida, history of abortion 1, para 1. Patient is in 28 weeks of gestation with episodes of sudden onset of brisk vaginal bleeding. There is no pain, history of 1 dilatation and curettage, history of 1 previous cesarean section. So what could be the most likely diagnosis? So here the cliche points are sudden onset of brisk bleeding, 28 weeks of gestation, no pain, and history of 1 previous cesarean section. So most likely it could be placenta previa. So then coming to next example, 34 years old, gravida 3, para 2, with 31 weeks of gestation. Again, here an episode of brisk vaginal bleeding, but here we find an abdominal pain, contraction, increased tone, no history of previous uterine surgery. So what could be the likely diagnosis? Here the points are brisk vaginal bleeding is there, abdominal pain, 31 weeks of gestation, and no history of previous uterine surgery, but there is increased contraction and increased tone of the uterus. So here most likely it could be a abruptio placenta. Coming to next slide. Another example is a 38-year-old female with gravida 5, abortion history 2, para 2, 36 weeks of gestation, again with a vaginal bleed, and she had regularly timed increased intensity of contractions. Most likely she was in labor, but subsided suddenly, and had history of, in her history we find there are 2 abortions, 2 cesarean sections, and there was a fetal heart rate variability. Most likely what it could be? It could be a uterine dehiscence or a uterine rupture. So here there was a vaginal bleed, there is increased timing contractions, and which subsided suddenly, which are the cliche points. Next slide, please. Now coming to diagnosis, placenta previa clinically, as we have discussed, it generally occurs with a painless vaginal bleeding. Preterm, generally we find it from 2nd to 3rd trimester, just before delivery as well. There is lack of abnormal tone, and exception is when there is a coexisting abruptio placenta. Coming to abruptio placenta, clinically there is a bleeding, tender uterus, increased activity, non-reassuring fetal heart rates. And for both of them, ultrasonography is of utmost importance. In placenta previa, ultrasonography transvaginal has become like a gold standard. So once the obstetrician or the radiologist, they have a suspicion of placenta previa, a close workup of how to go about with the patient plays an important role in the management of this patient. And coming to abruptio placenta, when we are suspecting an ultrasonography, looking for a hematoma and what is the size of the hematoma, where is the placenta separating, these all play an important role during the surgical process. Next slide, please. Double setup examination is installed in or is used in placenta previa when there is no access or limited access to ultrasonography bedside, and when there is a high likeliness that there is a likeliness for delivering of this baby, or when there is a brisk bleeding which is ongoing, and there is a conversion for there is no bleeding, but there is a high suspicion of placenta previa and there is fetal heart rate abnormalities. And so double setup examination is done with in the OT with one team towards the vagina and one team towards the head end of the patient, and emergency cesarean section at any point of this examination can be there. That has to be in the mind. Coming to MRI, when is placenta MRI useful is when in unequivocal ultrasound where there is no definitive diagnosis, or when there is a doubt, or when there is a very high BMI where ultrasonography seems very difficult, or when there is a suspecting accreta. In these cases, MRI can be used. And coming to abruptio placenta, immediately labs have to be taken into consideration by sending for CBC, clotting studies, fibrinogen, BUN, where and LFTs whenever we are of the doubt that the patient may go into severe HELP syndrome sort of a picture. Coming to management, it is like we are riding against the tide. So it depends upon the status of the patient at the arrival to the hospital, the trimester in which the patient is or the mother is, and the maturity of the fetus. All these three factors have an important role in the decision making. So in if the maturity of fetus is like around 31 weeks or 32 weeks, then whether to go for delivery or is there a scope for management conservatively. Coming to simultaneous active involvement of lab, blood bank activation and help, and asking for manpower, the doctors involved, staff, both technical and non-technical, transportation services, especially if we are planning, if we are having less equipment and there is a idea of transporting this patient in an emergent way, having a ambulance with equipment and personnel is of utmost importance. Coming to obstetric management, obstetric management considerations in placenta previa varies according to, as we have said, the maturity of the fetus, the status of hemodynamic status of both mother and the child. So delivery is planned when there is an active labor, when there is a persistent bleeding, there is a non-reassuring fetal status, and expectant management. Generally, it is also opted whenever there is a bleeding which stops spontaneously. In placenta previa, many of the times the bleeding can stop spontaneously, and the hemodynamic status of the mother and the fetus will not be in grave state in certain situations. So in those patients, the mother is admitted and monitored closely, keeping in mind maybe there will be a rebleed within a very short span of time, and to allow for fetal lung maturity. So at the same time, we have to initiate resuscitation to compensate for the losses, adequate IV access, at the same time fetal monitoring, and consideration for betamethasone or dexamethasone. Betamethasone 12 milligrams every 24 hours, 2 doses. Dexamethasone 6 milligrams every 12 hours, 4 doses. So if the baby is doing well and mother is stable, these doses we have to keep in mind may be needed to be repeated after 7 weeks, because the action will last for 7 days, not 7 weeks. Sorry. Next slide, please. anesthesia management, we have to understand one thing is that there will be simultaneous ongoing process of assessment of airway status, volume status, assessing of ongoing bleeding, and we have to whenever the patient comes, we have to look for these early warning signs like tachycardia, hypotension, pallor, oliguria, cool peripheries, and lower abdominal pain. Whenever these are there, we have to call for help as early as possible and start resuscitation, early resuscitation with large bore IV access, starting with infusion of warm fluids, sending for baseline investigations, cross-matching, and alerting our blood bank. And whenever possible, trying to avoid vaginal examination without a double setup. Next slide, please. So now the questions will be mode of delivery. What is the mode of delivery? Vaginal or cesarean section? And when is the delivery? Now or at a later time? Then neuraxial, is it neuraxial or is it a general anesthesia? Coming to mode of delivery, only when there is a marginal placenta previa or when there is a hemodynamic status of the mother is good enough and fetus is alive and fetal status is good, then vaginal delivery is opted. But still, when there is a complete placenta previa or where there is suspicion of large amount of bleed, then the mode of delivery will be general anesthesia, cesarean section. Again, in placenta previa, we have to understand in abnormal placentations, this has been on rise of abnormal placentations because one of the reasons is lot of cesarean sections have been being performed. So the cesarean section scar is a nidus for abnormal placentation. So when ultrasonography also helps in understanding where the placenta is and to avoid the incision through the placenta in certain in these situations. So when the placenta is on the scar or near the scar, it is better to change the incision into a vertical or a higher level, so that through incision through the placenta is avoided. So when is the delivery? If it's it again depends upon the maternal and the fetal status. So neuraxial or GA. Neuraxial, especially in abruptio placenta or with when the patient is in labor, and if it's a priorly we have instilled a epidural, that can be used for conversion in certain cases, especially if we are if the hemodynamic status is good. Also, an elective placenta previa patient where we have evaluated the patient and keeping everything ready, and it's an elective cesarean section sort of a thing where the hemodynamic status is very good and the fetus is very good. In that conditions, neuraxial anesthesia can be performed. And general anesthesia, whenever we are having a suspicion this might land up in massive obstetric hemorrhage, always it's better to prefer general anesthesia. So how do we prepare? Simultaneously ongoing resuscitation, evaluation of the airway, preparation of the drugs, planning for fluid warmers, considering invasive monitoring from the go or from the start of the patient itself in some cases. So for this, we have to understand that one person can't be doing all the things. So allocation of jobs early enough to various members of the team so that all are done simultaneously and quickly is of utmost importance. So now what drugs to consider during induction and maintenance? It's etomidate, drugs like etomidate, ketamine. These are relatively cardiostable and can increase the pressures. So using those drugs for induction and while maintenance, keeping in mind that increased amount of halogenated gases can cause more of relaxation and uteroanatomy and can increase the bleeding, and keeping all our uterotonic agents and pressors ready can be of utmost help during such cases. Next. So we have, as we have discussed, risk of lowering tone with relaxants, halogenated gases, and which can cause increased ongoing bleed. And the first line of drugs will be oxytocin and then carbetocin and ergot alkaloids. Ergot alkaloids in placenta previa, unless there is a proper removal of the placenta and a chance of retained products, if it is there, then it is better to avoid ergot and go for oxytocin. Oxytocin 20 units per liter at the rate of 20 mils per hour infusion. Carbetocin 100 micrograms bolus over 1 minute. And a note of abruptio placenta obstetric management. Conservative, again, it depends upon the rate of bleeding, the rate of change in the coagulopathy. Whenever there is an abruptio placenta suspicion, it's always better to involve a hematologist, radiologist, and labs as early as possible to because and if possible point of care management. And hemodynamic status of mother and fetus and the gestation play an important role. So, and also keeping in mind that these surgeries might not just land up only till the delivery of the baby, but may need conversion and may land up with a peripartum hysterectomy should be always there in our minds. Next slide, please.
స్లైడ్స్ కనిపిస్తున్నాయా?
అరే యార్, అదే నేను ఇప్పుడే చూసాను మేడం. నేను
కనపడటం లేదు.
సారీ,
అసలు కనిపించట్లేదు. నువ్వు అలా వేలో
my madam, mine, sorry, I'm really sorry, I didn't see, just now I saw. నేను నా ట్యాబ్ నుంచి చెప్తున్నాను కాబట్టి నాకు తెలియలేదు. ఒక్క నిమిషం మేడం. Are you able to see?
యా, మూవ్ చేయి.
కనబడుతుందా?
ఓకే, మూవ్ చేయి.
So I came to 13th slide. So sorry. I'll share the PPT into the group. So yeah, so this is in a nutshell about the management maternal. If the first we have to see whether the mother first and then the fetus, right? Mother, whether a mother is in shock or not. If she's in shock, resuscitation as soon as possible and planning for invasive lines, CVP, fluid replacement, blood replacement, analgesia, and arterial arterial monitoring for blood pressure, invasive blood pressure monitoring. And then coming to if she is in no shock, then observing and managing conservatively. And then the next will be fetus, whether the fetus is alive or no, and if there is a continued bleeding or pain, and what is the cardiotocograph showing, if vaginal delivery can be aimed for, and if it's not, then a cesarean section. And whether induction of labor is possible, and augmented if the fetus is not alive, then the plan will be to augment the uterine activity, deliver the fetus, bereavement counseling, and beware of postpartum hemorrhage. Antepartum hemorrhage tends to go into postpartum hemorrhage many of the times. Next slide. I only have to put it. The another grave issue is uterine rupture. As we have discussed, in uterine rupture, the patient will have abdominal pain. There will be an abnormal fetal heart rate. There will be bleeding PV, cessation of labor, which was generally progressing at a good rate, loss of fetal station, and change of presentation, and palpable fetal parts, and presence of hypertonia. All these have to be taken into consideration and help us to arrive at a diagnosis of uterine rupture. Again, uterine rupture, it is of two types: scar dehiscence, complete rupture. Scar dehiscence is like it is much safer than a complete rupture, because here there will be lesser fetal distress and lesser hemorrhage when compared to a complete rupture, where the distress, hemorrhage, and lining up of emergency cesarean section and going into peripartum hysterectomy is quite high. Coming to management, so obstetric management will be the ideas will be whether to repair, but there is always in the back of head, you have to always think there is a risk of re-rupture, and then to curtail the amount of hemorrhage, arterial ligation, and the definitive treatment will be hysterectomy, peripartum hysterectomy. But in peripartum hysterectomy, we have to understand that the uterus has not contracted well, and there will be a torrential amount of hemorrhage, and we have to be prepared for it. So once the peripartum hysterectomy is likely, then aggressive management and blood product replacement has to be taken into consideration. Coming to anesthesia consideration, similarly, like simultaneous evaluation, resuscitation, and preparing for an emergency laparotomy, and preparing our ICUs for a prolonged stay and a post-operative close monitoring and care has to be taken into consideration. Coming to need for GA is of more importance. Very rarely we'll have a stable patient with a pre-existing epi where it can be used for conversion. The major role here will be volume replacement, transfusion, and urine output monitoring, and need for invasive monitoring from the early time. So the ligation of arteries and peripartum hysterectomy. In ligation of arteries, the ligation can be to the depending upon the hemorrhage and depending upon the dissection at the time. The uterine artery, ovarian arteries, internal iliac arteries, the hypogastric arteries, these are ligated during ligation of the arteries. And peripartum hysterectomy, as I have mentioned, it is the definitive care in rupture. A note on vasa previa. Vasa previa, here the more danger will be for the fetus, because more likeliness of antepartum hemorrhage risk will be for the fetus than the mother. Likeliness of fetal demise is more. Early diagnosis in ultrasonography helps in planning for a better time to deliver the baby and when to deliver the baby. And especially when there is a hemorrhage with rupture of membranes associated with fetal heart decelerations or bradycardia, it is a very grave state for the resuscitation of the baby. And in such condition, in vasa previa, prior neonatology backup and neonatal resuscitation and transfusion, early transfusion of the neonate can help in reviving the baby. Coming to postpartum hemorrhage. So postpartum hemorrhage can be divided into a primary and a secondary hemorrhage. Primary hemorrhage, as we all know, from delivery to up to 24 hours. Secondary hemorrhage is from 24 hours up to 6 weeks postpartum. So it is because of abnormal placentation or because of uterine atony. The major causes of PPH will be the 4 T's. That is the tone, trauma, tissue, thrombin, and others. Tone, when there is a decreased uterine tone, the causes will be placenta previa, over distension of uterus, uterine relaxants, history of previous PPH. All these should be the cliche during our history taking when we are likely to face a uterine atony. And trauma, previous cesarean section, tears, episiotomy, macrosomia. These cause hemorrhage, relatively increased hemorrhage when compared to a normal vaginal delivery. Tissue retained products of placenta accreta, these can cause hemorrhage. The other thing is thrombin, preeclampsia, abruptio placenta, pyrexia in labor, bleeding disorders, hemophilia, and patient is on prior history of anticoagulants. These all can cause increased hemorrhage. The others are Asian ethnicity, anemia, prolonged labor, elderly age. Coming to approach of a patient with postpartum hemorrhage, we have a patient with bleeding PV after delivery of the placenta. Again, our ABCs come into play, and IV access, oxygenation, and further history and examination, bedside ultrasound, fundal massage, quickly alerting the obstetrician, giving oxytocin, and ruling out what could be the cause for the PPH, whether it is because of the tone, trauma, tissue, or thrombin, and then acting accordingly to prevent the ongoing PPH, ongoing hemorrhage, because the modality of treatment changes according to the cause of the hemorrhage. Coming to uterine atony, the conditions which are associated with uterine atony have to be known priorly, especially if there is a previous cesarean section, induced labor or augmented labor, and multiple gestation, macrosomia, polyhydramnios, high parity, precipitous labor, chorioamnionitis, advanced maternal age, hypertension, use of tocolytic agents to prolong the fetal maturity, high concentrated use of volatile agents. All these have to guide us and help us to think that this patient will have uterine atony. Coming to other strategies of managing hemorrhage, the use of uterotonic agents, surgical interventions, intraoperative cell salvage, interventional radiology, and hemostatic agents. Coming to uterotonic agents, the first, we have to know the first line drugs of uterotonic drugs, which are oxytocin, carbetocin. Carbetocin, it is expensive, but the availability, it's there in the city. And use of methyl ergometrin and misoprostol, which can be used by our staff, which does not need any injections and does not need more of skill there, and it is inexpensive, and it is photo and thermoresistant, and storage is not a problem. And symptometrin is a 1 ml drug, which is a combination of oxytocin 5 units and 0.5 milligrams of ergometrin, which is given IM. Knowing the drugs advantages, what are the first line drugs which have the longer duration of action, and how frequently can they be repeated, and what are the precautions, like oxytocin, if it is given rapidly, may cause hypotension, care to be taken in cardiac patients, and methyl ergometrin, caution during hypertensive disorders of pregnancy, or in a chronic hypertension patient, heart disease patient, retained placenta patients. In such patients, where to avoid, and carboprost 250 micrograms IM, and sometimes it is given intramyometrial, and the precautions where to be taken are like in asthmatic patients, reactive airway disease patients, where there is a compromised renal or a liver condition. In these patients, so when to give drug and how to give drug and when to repeat the drug is of importance. Coming to the surgical interventions, tamponade, bimanual compression. These procedures will be going on simultaneously in the patient, not that one will be going after the other. These all will be going on simultaneously. And bimanual compression is, as we have seen in the, as we can see in the picture, through the vagina, there will be a compression of the anterior wall of the uterus, and from the abdomen, per abdomen, the posterior wall of the uterus is compressed so as to decrease the hemorrhage. Coming to tamponade, there are many, the picture shows Bakri's balloon, but a simple method like Foley's catheter with presence of with the use of condoms and IV set saline, which can be put in every OT as a set, keeping it ready, and only to see the date of expiry and replacing these dates, replacing these life-saving catheters and all can be of help. And the other will be rush balloon and all. So this here we have to understand, when we are doing tamponade, the inflation of the balloon has to be after it has surpassed the internal os, so as to and it causes the mechanism of action is it causes the pressure over the uterine lining and to decrease the bleeding. So when we are, it can be left in situ in the uterus for up to 24 hours to 2 days. And when we are releasing the balloon, slowly 100 ml is removed from the balloon and seen for any signs of bleeding. If there is a bleeding, again re-inflation of the balloon and wait for the bleeding to control with the other ongoing methods. Then the other, though we will not be per se involved, but we have to know that there is a Belin suture and how the uterus looks like. So I've just put the picture. And the other is when there is an incision, the aortic compression through the open abdominal incision, where the aorta is compressed against the lumbosacral promontory. Next is estimating the blood loss. Estimating blood loss is a very tricky thing in a pregnant female, because the physiological changes of pregnancy can mislead the amount of blood loss which actually is happening. Visual estimation of blood loss is very misleading. Up to 33 to 50% of cases, there will be under interpretation of the amount of blood loss. But still, we have to know that the estimated blood how to calculate estimated blood loss, which is estimated blood volume into preoperative hematocrit minus postoperative hematocrit by preoperative hematocrit, and where estimated blood volume is in ml, weight into weight in kgs into 85 ml per kg. And drop in hemoglobin should be a cliche of more than 4 gram per deciliter. If there is a drop in hemoglobin, that will also have to alert us for a massive obstetric hemorrhage. And also quantified estimation of blood loss with the help of the pads, and having a quantitative or a pictorial way of estimating blood loss in our OTs, and having our personal OT, each and every OT, what is the weight of the gauze and what is the weight of the fully drenched pad, or a single gauze or a pad, or these can help us in estimating the blood loss in our OTs, and also educating our staff whether to alert us when there is a massive hemorrhage. So at the same time, having therapeutic goals like having a like HB more than 8 grams per deciliter. So what are our transfusion goals? Like having a HB of 8 gram, more than 8 grams per deciliter, a platelet count of minimum more than 75K, a fibrogen level of more than 1.5 to 2 grams. These should be our therapeutic goals when we are doing transfusion. At the same time, having massive blood transfusion protocols and access to massive transfusion packs with 4 units of O negative blood, 4 units of FFPs, 1 FFPs pack of platelet. Ideally, having a fibrinogen concentrate and a prothrombin complex concentrate along with the pack will be of help. coming to intraoperative cell salvage, it is gaining its importance in the OTs. Having a cell saver is it's like a luxury, but having it can save a life. But because of it, the cost constraints, sometimes having a cell saver in every place cannot be feasible. But we have to know how it works and the working principle. So once we are collecting the blood, it is mixed with anticoagulant, and it goes to a reservoir, and saline wash is done, and centrifugation, and in some places there will be a filter leukocyte which depletes the leukocytes, and the waste is collected separately, and the packed RBC, after they are washed, they are collected in a reinfusion bag and help for reinfusion into the patient. How does it help? It prevents a lot of autologous transfusion and transfusion related immune reactions. And it is life-saving when the blood is scarce or there is a rare blood group, or when immediately you can have a blood available during an ongoing hemorrhage. A note on viscoelastic testing and point of care. TEG and ROTEM have slowly gained their importance in massive hemorrhage protocols, because it gives us the results less than about 30 minutes to 1 hour during an ongoing hemorrhage, and what to replace, how to replace, and when to replace, and how much amount to replace, and whether our replacing components have their effect and the hemorrhage is being controlled. It can be assessed very well when we use viscoelastic testing. Coming to a role of interventional radiology, a center which has a good trained interventional radiologist in your team or in your hospital can be of great help in ongoing hemorrhage cases. The advantages are we can have a better and accurate control of bleeding, because they are actually going and blocking the site of bleed or the artery which is causing the bleed, and it can be done in deranged coagulation state. And what are the disadvantages is it needs a trained setup, shifting of the patient to the cath lab. In the cath lab, again, interventional radiologists should be available 24/7 to assist for emergency conversion of the patient. In the cath lab itself, the surgery might need to be performed. So again, surgery in a remote area is a place which we have to be prepared for. Coming to our note on hemostatic agents, the tranexamic acid and recombinant factor 7A. Tranexamic acid, the women's trail and crash trails have shown, and WHO recommends early use of tranexamic acid less than 3 hours of birth, or as soon as possible after the onset of bleed. And it is as we all know, it's a synthetic derivative of lysine, and it has a path in antifibrinolytic activity. How is it to be given? 1 gram in 10 ml IV at a rate of 1 ml per minute. And second dose if bleeding is persisting after 30 minutes, or if there is a restart of bleed after 24 hours. Coming to recombinant factor 7A, if you have a consultation with hematologist, it could be of help. It is a off-label drug, expensive, availability and is an issue. What is the mechanism of action? It acts via tissue factor dependent and independent pathways involving factor 9, 10 and thrombin generation. And what are but there are few prerequisites. That is, the hemoglobin should be more than 7 gram per deciliter, fibrinogen minimum of 1 gram, and INR less than 1.5, platelets more than 50K, pH more than 7.2, and a preferable normothermia. Why we need all these prerequisites is it acts on all these components, and there will be a consumption of the factors once we are using recombinant 7. So unless we replace the components, there is no point in giving factor 7A. So these are my references. In conclusion, we should all know that because we know that there is a high mortality and morbidity So accepting the likeliness to come across an obstetric hemorrhage in our careers, then only we will try to prepare for facing this hemorrhage, and having a hunch to look for and identify early so that we can treat it better. Having a discussion among team and having drills for being prepared, and having case scenarios to be prepared, and knowing our workplace strengths and weaknesses, when to shift and where to shift, and likely scenarios where to shift and how to shift. Utilization of the available resources efficiently, understanding the need for early involvement of various specialties, and having a good organizational support and healthy interaction between the tertiary units. So, thank you all.
Thank you, Chandana. Can I add few points?
Please, madam. Please.
Okay. So here, which condition we have painless bleeding and which condition is a painful bleeding?
Painless bleeding is with placenta previa, madam.
Okay. And the painful bleeding?
Abruptio placenta, madam.
So consider
Also
type of
uterine
abruptio
rupture
placenta.
Yeah.
Okay. So these are the questions for DNB students, and you have to add slide classification of hemorrhage.
Yeah.
Okay.
Okay,
These patients are what type of what stage coming is stage 2 or 3 like this.
Yeah.
Next,
I forgot to mention, madam, mild hemorrhage,
okay.
moderate hemorrhage.
Okay. Okay. Next, third is what is
open గా
low
చెప్పండి.
lying placenta?
చాలా బాగా చెప్పావమ్మా.
Sir,
you,
she is
అంటే
preparing
స్టార్టింగ్ లో
preparing
చెప్పిన
for
మధ్యలో వినలేదు.
sir, she is preparing for obstetric
తెలుసు,
anesthesia
తెలుసు,
in workshop.
చూసాను KGH లో ఉంది కదా.
Yes, sir. Next,
చూసాను.
what is low lying placenta?
Okay.
నేను చిన్న మీటింగ్ లో ఉన్నానమ్మా, ఫోన్ చేస్తాను.
Okay.
Okay.
So a low lying placenta, how to diagnose is ultrasound abdomen. We can see in the first trimester also, but no need worry. And later on, the when you are doing the scan, placenta is not changing the position. At that time you have to worry. Okay.
Yeah.
Next, already you told about antepartum hemorrhage classifications, and massive transfusion protocol you told about little bit. And what protocol blood transfusion you are starting is 1:1:1 like this you have to tell. And during resuscitation, don't aggravate crystalloids. You have to add blood because hemodilution. So oxygen delivery capacity is reducing, tissue edema, acidosis. That's where you go for blood transfusion.
Consent to yeah, correct.
Yeah. Next, uterine rupture. When uterine rupture, it is operative or non-operative. Operative means previous history of cesarean section. Non-operative means lower segment is thinner. That's why because of prolonged labor, that's why is uterine rupture. So that is the thing. And in PPH, you can divide treatment pharmacological, interventional. So pharmacological, you told about oxytocin, ergometrin, prostaglandins like this. Present ergometrin stopped because of severe headache. Later something I don't know exactly. So that's why ergometrin stopped. And interventional, you told about the suturing, tamponade effect, embolization, and hysterectomy. What about the anesthesia techniques? So in anesthesia, you can use inhalation, no? So less than 1 mAc we have to use in general anesthesia. Okay, that is also important. And a patient coming for retained placenta. So what induction agent you want to use means anything you can use, but sub-anesthetic dose of ketamine is enough for retained placenta. And you told about
ఇంకోటి మేడం, యుట్రైన్ ఇన్వర్షన్ ఉంటది కదా మేడం. ఇన్ దట్ ఇనిషియల్లీ యూ హ్యావ్ టు కాజ్ రిలాక్సేషన్ అండ్ ఫాలోడ్ బై ఇంక్రీజింగ్ ద టోన్. so that after you replace the uterus, you have to increase the tone so that there will be no Mali, it should not come back. So recurrence stop chudant. So how
Okay.
do we do?
Next, in the management is what is hybrid procedure? And hybrid procedure means so embolization is doing
ongoing with
first you have to do embolization and immediately you have to do hysterectomy on the table. So that is the hybrid procedure. So OT and cath lab everything in one setup only. And cell salvage means which patients is most useful means Jehovah Witness and refuse. That patients will be more useful. Here main problem is contamination of amniotic fluid.
Various suction, separate suction is being used.
Separate means dual suction we have to use and remove the amniotic fluid. Later saline wash and transfuse the blood. Like this you have to tell, and cell salvage technique. And add one point, rapid infusion. So rapid infusion level 1 and level 2. Why you are using means it is gives a warm fluid with a pumping push of 1000 to 1400 ml. So that point. And what is massive obstetric hemorrhage?
A definition of massive obstetric hemorrhage.
Yeah. And
more than 500 ml in vaginal delivery, more than 1 liter in cesarean section. That is again moderate and severe. Moderate is 1 to 2 liters and more than 2 liters is severe.
So here the most massive obstetric hemorrhage means more than 4 units you need, more than 1500 ml blood loss, hemoglobin fall more than 4 grams. So poor outcome of MOH. It may be delayed treatment, unavailability of blood and blood products, inaccurate estimation of blood loss, absence of treatment of protocols, poor communication among the treating teams, and inadequate organizational support. So these are the poor outcome of MOH. And multidisciplinary team approach means anesthetist, transfusion medicine, and obstetrician, and nurses and radiologists. These are all teams we have to alert in massive transfusion protocol whenever patient obstetric hemorrhage. And you told about massive transfusion pack. That is always and keep in blood bank O negative. 444, no? These are the things from my side. Any questions from audience?
How to diagnose a threatened rupture of uterus clinically?
Sir?
How to diagnose clinically threatened rupture of uterus without any help of investigations?
There will be sudden cessation of contractions with the proper ongoing contractions, or and pain, the tone will be increased, and there will be fetal heart rate variabilities, palpability of fetal parts, suddenly the change in the
I turned with threatened rupture.
Threatened, sorry. Fetal heart rate variability. Please add on, sir.
Maternal heart rate is always above 130. Impending shock. So before giving a spinal to, and a history of our previous cesarean section. So always while giving a spinal to for a cesarean section, always look at the maternal pulse rate. If it is above 130, you should always, if patient is afebrile, think of threatened rupture. And pain in the abdomen, vague pain in the abdomen. మేడం 4:4:1 అన్నారు. ముందు 1:1:1 పెట్టాలా?
అది ట్రాన్స్ఫ్యూషన్ ప్యాక్ చెప్తున్నారు సార్. మాసివ్ ట్రాన్స్ఫ్యూషన్ ప్యాక్ సార్ వేరు, అది ట్రాన్స్ఫ్యూషన్ ప్రోటోకాల్ 1:1:1.
అంటే ఎనీ పేషెంట్ we can start sir O negative group. So 4 units RBC, 4 units platelets,
availability
4
of
units
transfusion pack in the blood bank sir, 4 packed RBC.
So a note on dick also can be made.
Yes sir.
Pharmacological uterine tonic drugs. Can you name some?
Uterotonic drugs చెప్పాను oxytocin, carbetocin, methylergometrin, carboprost, misoprostol, symptometrin.
Ridotrin ఏంటిది?
చదివాను కానీ ఫుల్ గా చదవలేదు సార్. సో ఐ కాంట్.
రిలాక్సెంట్ అనుకుంటా కదా సార్.
అది టోకోలైటిక్ డ్రగ్స్ లో ఉంటుంది సార్. టోకోలైటిక్ డ్రగ్స్ రిగోమెట్రిన్స్.
టోకోలైటిక్ చెప్పలేదు. టోకోలైటిక్ డ్రగ్స్
చెప్పలేదు. టోకోలైటిక్ డ్రగ్స్ చెప్పలేదు.
నైట్రోగ్లిజరిన్ is one of the tocolytic and ridotrin.
అవును సార్. ఈవెన్ సమ్ టైమ్స్ మ్యాగ్ సెల్ఫ్ కూడా and inhalation kuda that is what I was mentioning in the last uterine inversion unte when we have to relax first and then we have to increase the tone.
తర్వాత placenta previa grade 3 and 4 you have to plan
selective cesarean prior itself found sir.
గ్రేడింగ్ అదే మేడం చెప్పినట్టు ప్లెజెంటా ప్రీవియాను యాక్సిడెంటల్ హెమరేజ్ గ్రేడింగ్స్ చెప్పాలి.
అలాగే సార్.
తర్వాత ఈ అనస్థీషియా ఇచ్చేటప్పుడు ప్రీ ఆపరేషన్ లో you have to do 3 minutes.
RSI కూడా మెన్షన్ చేయాలి. రాశాను కానీ చెప్పలేదు సార్. చెప్పాలి.
నైస్ ప్రెజెంటేషన్ చందన.
థ్యాంక్ యూ సార్.
Hi Chandana.
Hi madam.
Hi. Nice talk, and you're doing it in anesthetist workshop kada.
Avunu sir. Avunu madam.
Yeah, as Prasad sir said, you have to don't forget about rapid sequence and antacid prophylaxis, because usually they go for emergency cesarean, right? So avi marchipoddu, and practical points you have to stress more, right? So and consent and possible loss of fetal loss avanni counseling lo explain chesevi, and if you think baby is not alive, you have to document in your note, because that can be a legal issue. Ilanti vatilo legal issues kuda we get into, so you have to note it down. And like as I came to know recently, if you think that's a IUD because of abruptio or something, you have to have a proper report of a radiologist or sonography certified obstetrician notes. So otherwise we get into trouble if we do that. So Adi, you have to mention, document about the fetal condition.
Sure.
So before taking adokati, and post operative and post procedure they have to be monitored in HDU or ICU. And in abrupt show cases, you have to continue to monitor and control the blood pressure and prevent patient getting into eclampsia. So Maxwell full Abitlol avanni post-op kuda continue cheyali to control blood pressure and prevent eclampsia. And monitor for signs of imminent eclampsia. Yeah. And sometimes we may see when they come with a severe abruption and a lot of blood loss, they'll be in lot of pain, tachycardia. So with that tachycardia, they compensate and have marginally high blood pressure, like 120, 130, but don't assume that's their blood pressure.
So once we start induction, they crash down.
Yeah, exactly. Usually we go for GA and don't even think of regional, because as soon as you give, they just collapse. So go for a rapid sequence and they'll just whatever anesthesia give, prepare for like a rapid infuser, fluids, or get blood ready and blood products ready before going into theater. If you think it's severe, like a high grade hypotension, more than 1,500 to 2,000 loss pre-op itself, then you have to have some in hand. And post-op care. So I'm monitoring for organ dysfunction post-operatively, AKI and all those. Monitor output avanni. So legal things, post-op care and pre-op preparation and counseling.
Okay, ma'am.
Documentation very important in all these cases. Yeah. Okay. Thank you. Bye.
Okay, ma'am. Thank you.
Any questions?
సండే బ్యానర్
ఉండవే బాబు నువ్వు.
అదే అనుకుంటున్నాను సార్, బ్యానర్లు కట్టి
కామెడీలు బాగా.
క్లోజ్ చేసేద్దామా సెషన్?
ఓకే మేడం.
Okay. Thank you so much. Thank you, Chandana. Thank you, Rani Madam, Ramana Prasad, all seniors and
No, I am really grateful for all the inputs. I'll try to include all of them. Thank you so much. Thank you.
Thank you. Please use laptop. Thank you.
Sare madam. Okay madam. Thank you.
Finally gone.
Thank you. Bye.
Thank you, ma'am.
Bye.
Thank you to all.